Hello there, everybody. I hope you are as excited for this episode as I am. This week, we talked to Ben, who works in urology. He is killing it on social media. He is so funny, so genuine, and so smart. I did want to give you guys a quick debrief disclaimer. I did have some audio problems at about 20 minutes and 56 seconds, so the audio quality sort of drops down. But I did so much editing, which is why this episode is late. And I think it's still, listenable. And I hope you still really enjoy this episode. I had such a fun time making it, and I hope you enjoy it too. Let me know if you guys have any questions, and we'll jump right into the episode. It's actually this is the most awkward part of the entire episode because I don't totally know how to segue into starting the episode.
Okay,
But for the listeners who are listening, I have Ben here. Ben works in urology. I'm going to go ahead and let you give yourself your little introduction. So just tell me a little bit about who you are, what you do, and then we'll get right into the episode.
great. So, hey, folks, my name is Ben. I'm a urology PA. I've been practicing for a little over 5 years now, exclusively in urology. Really happy that Izzy let me contribute with the White Coat podcast for today. So I'm really happy that hopefully that anyone's listening is enjoying and take some good learned facts from today. But honestly, it's just my experience. I'm a pretty chill person, so hopefully this is productive and you can learn something through it.
Yeah, I think it will be. I'm really excited. I'm really glad that you reached out to want to be on because I actually really wanted to possibly get into urology. And so it's a specialty I've been really fascinated about because it's not something you get a ton of exposure to when you're in PA school. So if
Mhm.
you could just start by telling us a little bit about why you decided to go into urology or what was your motivation or exposure? How did you find it? I mean, this is the only job or only specialty you've done, I guess.
Yeah. So with me, I think urology is great, but of course, it depends on what your goals are. For me specifically, before PA school, I got my patient background care, and basically, I was working on oncology research, and specifically, it was for GU cancer, so prostate, kidney, and bladder. Of
Mm,
note, being involved in the oncology side, it's kind of nice having been involved with some cancer treatment drugs now that I was a part of on like phase 1 trials years ago. So that was nice to kind of keep it all together from in the long haul. But honestly, for me, that's kind of where I got my start. That's where I first started interacting with some really good PA mentors, and that sort of fed me into school. Um, where I went to a Duke, it was a 2-year program. First year was our didactic, which is didactic, and then it really got fun with clinical. My first rotation was an elective. It was urology, and I was happy. I
mm,
chose that, but it just happened to be the first rotation. I had an awesome rotation. My mentors were great. The hours were pretty good. I met some pretty good residents too, good OR exposure. It was
mm-hmm.
pretty much like an ideal rotation where I think if I had it towards the end, it kind of set the tone for the rest of my rotations. I think the next one I had, no offense to anyone that's looking into it, I think I had inpatient psych afterwards too, and I was like, yeah, no,
Mm-hmm.
I want to
It's
stick
like,
with urology.
not for me, not for me.
Yeah. And so it was just more of the experience. Probably if my mentor was, not nice to me, or if the hours were just terrible, or it was just horrible I feel like I wasn't retaining anything. I'm more drawn to things that I'm better at or enjoy, more path of least resistance. So it was just the environment that was good. Um, After, PA school, I had trouble getting a job. So my school was in North Carolina. I didn't think I even got one job interview in the entire state.
Yeah.
So I kind of opened it up. Urology was my most of my background. I'm like, all right, as a new grad, I have the most weight I can throw behind it. Kind of got job offers or interviews kind of all over. I almost went to Pacific Northwest in
Mm-hmm.
Oregon, almost signed on a job there. Then like a week later, I got a job in Atlanta where I'm now too. Um, and as for why I like urology, since that first job, you've kind of worn a lot of hats. And you can feel free to get me on track here, so I'm not just going off the rails
You're
here. But
good.
But with the urology gigs, it depends on where you go. I've been in private practice. I'm in a university hospital now. I've sort of worked mostly in sort of like the men's health space, but you get a whole lot of general urology, oncology, kidney stones too. So there's a lot of things, even though urology as a whole, I think PAs, I think we're maybe like the urology is maybe like 3% of the
Hmm.
entire PA segment that we are. So it's not a whole lot, but within that, there's a lot of different things that you can with different like disease states that you can deal with. And then of course within that, you can focus more heavily on outpatient side. You can do lots of procedures in the office if you want to, use your hands. Speaking of hands, being a surgical subspecialty, there are a lot of
Hmm.
surgical roles that you can do. Some people can be purely for surgical assist. I'm kind of in this weird transition, which has been exciting, where maybe a year ago I was doing mostly inflatable penile prosthesis (IPPs),
Hmm.
and now I'm doing nearly primarily robotic surgery cases too, which wasn't even exposed to even really in school for maybe one case, but I started doing robots 4 years into my career, and it's been pretty cool. So you get to have those different hats. And then, of course, there's the inpatient side too, where we have, being a university hospital, we round on our cases as well. So you get to see a lot of sick patients, some not as sick. You still get to dabble a little bit with some general medicine patients, but you kind of focus on what do I have to do. So for me, it's been pretty dynamic. And I'll wrap it up with, I feel like most things within urology we can do something about. Most of the stuff there's not just a guideline that we follow, but most of the time, at least we can offer, okay, here's the plan. You're not, for the most part, just
Hmm.
saying, all right, we just got to deal with it. Doesn't mean that you don't get complex cases or sad cases too, but I feel like you're able to offer something tangible that patients can say, okay, this is what we did, or this is what we will do. I
Right.
found those conversations tend to be the most uplifting.
Yeah, absolutely. No, that's such a great answer and segue. Well, and I will segue real quick because you mentioned Duke, and my best friend lives in Durham, so I actually am very familiar with the
Awesome.
Duke area. So Enzo's
Hmm.
is that's my go-to pizza place whenever I
Oh
travel
yeah.
there. And
Yeah, they
I
they had
always
that
talk
place.
about it.
It's a fun spot. And again, maybe wherever you went for school or whoever's listening to, your environment's going to change where you go. So, do I think that everyone has to jump into urology, or will some people hate it? I'm sure some people do.
Sure.
But I do find that if you find a good opportunity and it's calling towards you, you always just try, and you won't know unless you try.
Yeah, and you've hinted at this a little bit with your kind of where you're at right now in your job description, but can you give us a little bit more information about what specifically you're doing now as opposed to maybe what you first started out with?
I would say most roles, which is actually nice that I'm not doing anymore, is call. No more
Yeah.
call nights for me. I was in private practice, so the difference between private practice and like university medicine, hospital medicine, it's a whole different ball game. Yes, hospital, groups you can still do call, but where I'm at, we have residents and they just don't utilize PAs for it, which is awesome. I didn't realize how great it is until my first night of not having call in 5 years or not being on the call list. That was great. Obviously there's benefits to it if you like your job, if you have, I did learn a lot through on call, having to triage stuff on your own at 3 a.m. in the morning, waking
Right.
up and having to talk to the ER team too. I'm glad I got that exposure to kind of build up my base. But that it's nice not to have to do anymore. But right now, I still, besides the lack of call, it's kind of been still those three hats in general. Even private practices, they still need to sort of feed off of any local hospital system to get their volume of patients. So most places do have call. Most places will have clinic time that you have to see your general urology patients too. Even though I would mostly be, if I had my attendings that were more on the men's health side, still see plenty of UTIs, urinary incontinence,
Hmm.
prostate cancer, men's health. You still see it's a lot of different things too, and prostate issues, and many others. So you're still going to see a lot of your bread and butter cases. Um, the learning curve took me about, I don't know, I felt like it took me about a year to really, no, I don't know, definitely know plenty of things I don't know. It probably took me about a year of trying to get to a spot where I can kind of just know what I'm doing. I don't have to,
Hmm.
stress out a whole lot. But you eventually you get the hang of things, especially if you have a good mentor and you're having a good environment where you feel like you're being supported. That's the biggest thing.
Right, right. What kind of procedures do you get to do in this specialty? Because I know I can think of
Mhm.
a couple, but probably there's way more than I know of.
I mean, there's quite a bit, and it depends on your state, your attending's limitations on you. If you have an attending that wants you to work you the full, uh, full scope of our practice, that's great. If they feel like your ceiling is their ceiling, what they allow you to, especially if they are going to be willing to train you. So for procedures, it's always varied. In the office, you can do pretty, rather to me nowadays, are kind of mundane. We do a lot of like injection therapies
Hmm.
if you like to do injections or are trying to get into a space that does do injections or the dermatology or the aesthetics field, you can get a bit of experience on the urology side where we're doing like penile injections for erections or taking them down,
Yeah.
injections for Peyronie's disease or curvature of plaques. And speaking of the genitals, we do a lot of hydrocele aspirations and drainages. Of course, you get your occasional scrotal abscess too, which you'll see in the ER very often.
Right.
Those are kind of like those. And in the office too, it kind of depends on what your setup is. Um, we do these types of basically it's nerve stimulation tests for helping bladder control. So it's kind of like acupuncture for your bladder. I've done those for a
Okay.
while. You can range from doing certain injection therapies, although most places will use nurses for that too. Those are kind of the most of the like pretty basic, procedures. And then, of course, depending where you go, you can assist on office like procedures too. Our office will have cystos come in, so sometimes my doc
Hmm.
will need another extra pair of hands. I've assisted plenty of times on vasectomies too. Um, Depending where you go, you some PAs actually will be able to do more of those procedures more heavily than without the doc too. In some places, we'll do even more advanced procedures assisting where you're doing a cystoscopy, you're in the OR, helping place
Right.
stents, helping without ureteroscopy too. We'll do first assisting in surgery cases where you're really needed equally as well as the doc because you need to work on two ends of the body, up in the kidney and working on stents from downstream. And then, of course, there's the whole world of robotic first assisting, which I'm in my
Yeah.
first year of. That is, you learn to build your reflexes pretty quick. So yeah, there's a lot that you can do should you choose to have it. But I think most places are pretty, um, well, most places should be pretty open to you sticking to what you find is most enjoyable. There's
Right.
a lot to do.
Yeah. I know my attendings are also entering the robotic game, and it's
Yeah.
been an adventure, and the training's been very cool. We've gotten to we've been sending PAs alongside the attendings to go get the training, and now we're doing them in our facility. But it's different. It's definitely a different experience being in that room than any other type of surgery I've ever done.
Yeah, and they can be arduous too. And now, yeah, there's the cons of it too as well. It's still a surgical specialty. You can still have some long days, especially if you're throwing call
Hmm.
on to it as well. Some days you have your set list of patients that you're going to see, but you get called to the hospital and you got to make that work. There are days where, yeah, we have a robot case that was supposed to be 3 hours and it's 8 hours later, trying
Right.
to time yourself, trying to go to the bathroom. I'll have some days where not a lot, not a lot, but some days where I'm like, you're kind of beat afterwards too. So you can have those, but honestly, I don't find myself at the end of the week. I find the week goes through and I'm able to enjoy my free times. So
Sure.
it's not perfect, and a lot of it is the team that you're with and just who you work with as well. And that goes for any I think it goes for any place that you're at for employment too. So I'm in a good spot where my team is pretty solid.
Yeah, absolutely. Do you have any, I guess, clinical cases or areas of focus within your specialty that is kind of your, I always call it like your golden nugget? Like, is there a condition or an area of urology that lights you up on the inside? You could talk about it for hours and
Mhm.
hours, and it's almost like a personal passion.
I would say, no bias to any types of cases that we see, but I really love working with our VA patients. We're in Atlanta, we have a VA hospital of our own, but just for whatever reason, we'll still see some that'll come to our university hospital too. And I don't know, I just sort of like the VA patients tend to be really straight shooters.
Yeah.
They may be a little rough around the edges. They'll say, okay, I may not like this, but I'm going to do it. Not that
Hmm.
we just want someone to they just follow orders, so to speak. But I do find that they tend to be very appreciative if you kind of know, if you kind of connect well with them too. I don't have a military background, but this is my way of, I feel like, being able to give back to our veterans too, because it is a really underserved population, especially in
Absolutely.
urology. There's a big chunk of men's health and, screenings that we do, prostate health screenings too, men and women as well. But there tends to be a population, at least where I'm at, where I feel like access to care, quality care, isn't always there for the amount of volume of veterans that we have.
Hmm.
And it's nice to be able to contribute directly and provide direct care in that space while not necessarily only having to be in the VA system.
Right, right. You still have some opportunities to kind of keep your hands in multiple patient populations while staying within your specialty, which is really
Yeah.
nice. So, if you could think back to 5 years ago, for me, I'm like, it's only been a year, but I can't imagine
Uh-huh.
kind of being in your shoes a little bit. But what was the hardest part about your transition from your PA student career transitioning into being a provider? What was like one of the major challenges that you experienced?
I feel like I can feel it. I remember the first day that I had to basically man the clinic by myself. I haven't thought about this for a long time. I think it was maybe my second or third week, and for whatever reason, I was kind of just following along my doc because I was a brand new grad, and as you know, you're kind of doing a lot of on-the-job training. You're learning how a certain clinic works. You're just learning how to treat, especially the way how your provider treats too. I don't know how it is at other schools, but the part we covered for urology, it was only like 2 or 3 days, maybe, outside if
Hmm.
you even had an elective too. So we didn't come in. And also, my urology rotation was a year in change even before. So I was pretty rusty. But yeah, I remember that first being terrified of that first two patients. That was it for an afternoon. And I had the sweats. I was breathing
Yeah.
heavy. We got through it. So the biggest thing was just for me getting exposure to enough volume and seeing enough of these standard, cases that you kind of know what to do, that you kind of follow the guidelines, making sure while I don't feel like you have to go home and study every single night, I want people to live and
Hmm.
enjoy their lives. But it was helpful to utilize whatever resources that I had, and there are some I can recommend down the road that would help me get up to speed to get my basics too. And then, of course, just being confident as well, like knowing that, all right, knowing what you do know, knowing what you don't know, and then just having
Hmm.
the confidence that you're in a clinic or a hospital or a group that's willing to support you.
Right.
My first role, I was happy to get it. I was one of those few. I didn't last longer than technically even like 4 months. It was not
Okay.
a good environment for me to really grow, and it was very stressful. It wasn't until I had my next job that I was like, oh, this is how it's supposed to be. And it was a completely different experience. So giving myself time to adapt, knowing when I'm in an environment that it's not conducive to my mental health or my skill
Right.
set, and then finding a group or a home that everything feels right.
Right. So would you say that was one of the um I guess what is some of your tips for a new grad who's looking for a job in a
Mhm.
niche specialty like urology or like
Yeah.
myself, I work in trauma surgery. How do you, you're trying to get a job in a specialty that's so niche already, and now you're having to
Mhm.
also possibly compensate by taking a not so ideal job for one reason or another. Are there any ways that you can kind of filter through those jobs or areas that maybe you're flexible on location or maybe you're flexible on taking call? Are there any tips that you have in regards to that?
Yeah, I mean, maybe not. I wouldn't say it's specific to urology, but depending on where you want to go, if there's a space, a job that you want, or a type of job that you want, yeah, for path of least resistance, if you have the luxury of being mobile, I was after school. I'm not from North Carolina, so like, oh, I'm actually
Mhm.
from Boston, so like I already moved, all the way halfway down the south. Let's just keep going where I need to go, and I'm in Georgia now. But I remember trying to find my own state. I didn't want to go back up home north, and again, I almost moved to the Pac Northwest. I was
Mhm.
looking at like in the West Coast for a while too. I was kind of applying all over. And yeah, I didn't like many people may have had. I think I applied for probably 100 jobs in general. I think I threw some ortho jobs in there.
Sure.
And in the end, I think I got 6 interviews with maybe 2 or 3 offers in the end,
Hmm.
maybe even just technically two. So it can be a grind, but you just got to stay on it as well. I ended up getting a job within a like couple of weeks of passing my boards too. Don't always advise it because it gets kind of dicey when you're actually
Right.
certified and you're allowed to work. But keeping your location open can be helpful. And then also when you're applying, trying to make yourself appealing is going to be tough as a new grad. Trying to utilize, okay, maybe I didn't have urology experience, but I was like,
Hmm.
okay, when I was in general surgery, we did these types of procedures. You kind of focus on the things that you can have some application to. But at the same time, you're still going to be looked at as a new grad, and there's always, it's going to be tough to come out of that
Right.
box when someone's looking at you as an employer. But honestly, once you're a year in the game, I remember I had a job for a year. I wasn't even trying to leave. I think I put in like a couple applications, I think 10. I
Mhm.
was just kind of let's just see what happens. I got calls within that week from like seven or eight of them.
Wow.
Whereas before I was a 6 out of 100, I was at
Right.
batting 80% too. So it doesn't take much experience to make you very appealing in a small specialty like
Right.
this.
Well, and I know you mentioned earlier too about how I think you mentioned 3% of all PAs work in urology. I found the AAPA report from 2021 and it was only 1% of PAs. So
Oh,
there's growth. So there's growth, but that's still quite a low number. Do you have any idea? I'm just not familiar enough, maybe, but why do you think that that is? Is it that there's just not enough job opportunities because it's so small or niche of a specialty? Is it for any other reason that you can think of, or just maybe people don't know about it?
I think it's just the specialty as a whole isn't a huge market share. But within PAs, I think we're utilized pretty well. We're trained in the medical format too. So generally, I feel like all of my attendings have been pretty fond of having PAs too. And there's a mix of NPs and PAs, but if you're looking at OR time, yeah, that I was saying from before as to why I think the urology PA market share is small, I can't really say. Overall volume from urology itself, I feel like there's a lot of jobs. I mean, depending where you go, but every mid to large city in the U.S. has urology clinics, and they're all seemingly wanting to expand or absorb into other groups too. It's pretty competitive, and if you come in with some good background and you interview well too, I think you'll want to get snatched up pretty easily too. There's space even where I worked as well. We have a pretty decent sized team, and we had some vacancies for a while. Just depending where you're at, it may not be as attractive as other fields, but they're out there. I think if people want them, I think that you just got to go out and go after it.
Sure, sure. And I'll kind of lead us back into some clinical questions that I have because I'm guiding us. Now we're moving into the questions from listeners.
Yeah,
But one of the biggest questions I had like maybe three people mention this. And I'm sure you get this question frequently on your own, pages that you work with. Urology often involves such sensitive conversations or conversations that are very stigmatized. What have you felt has been able to help you broach those conversations
yeah.
with patients and help settle nerves or just allow patients to maybe open up enough to get the information that you need to do what you need to do?
Yeah, everyone has their own way of connecting with patients too, and just connecting with people. Some folks like someone that's a little more relaxed. Some folks like someone that's more straight edge or more conservative too. I had one thing for my urology rotation. I got a comment. I got my urologist gave me a good score, so that was good. And the one
Yeah.
negative, not it wasn't negative, but the one thing that I should improve, he said Ben should probably lighten up. And I didn't really get that at first, but then I kind of did. I was so used to trying to respect the student, uh, your student and preceptor relationship too. But you need to be able to relax and be yourself and not just think of it as you're in the military or anything too. It allows you to bond with your providers and the team that you work with more. And that sort of carried over into how I talk with my patients. Not everyone likes it, but what the way I do when we're having sensitive topics, I talk to folks where as if I'm just talking to a friend, using slang or just coming in, not making it sound too much medical jargon. You're just sitting down with somebody, calling things what you normally call them, And
Mhm.
depending where you go and what region you are, you'll have to be familiar with certain slang so you know what people are talking about. I just try to keep it pretty loose. And if someone sees you, if you're having to do a genital exam on somebody and that you've just
Right.
met within a minute or 2 minutes, other
Mhm.
contexts out of medicine, that can be very awkward. So when you put it into this sterile environment, fluorescent lights too, it can be very nerve wracking for a lot of folks who probably may not even wanted to even be there. So just by yourself being more confident in your own skill set and knowing that, hey, we're just going to
Mhm.
have a conversation about what you're here for, I feel like that helps folks calm down. They don't feel bad about telling what's on their mind. Because as most folks will probably say, yes, there's things that we always want to treat, but a patient's goals are important. But if they're sort of reserved because they don't trust you, because they think you're just coming in as an official, I like to meet people at
Mhm.
ground level and just say, hey, what can we talk about? So being a little more relaxed, at least within your conversation, but making sure when you document, you cover all the things that you want to do
Right.
in your note too. So that's been my approach, and it helps me relax more and it makes it more enjoyable.
Right, absolutely. Because I think this is such an important conversation in general, because this is important, for example, if you work in psychology or even in, many other specialties where you're dealing with not just perhaps conversations or situations that are stigmatized for one reason or another, but also your background is in oncology. So you're also having perhaps devastating conversations with
Yeah.
patients. So you're delivering terrible news at times in an area like the genital urinary system, which is already an area that people maybe don't even think is appropriate to discuss at all. Um, I guess very much on the same path. How do you approach maybe delivering bad news to patients?
Yeah, those are always tough. Right now I've had enough of these, those difficult conversations too, which doesn't mean that they're always easy, not at all. Like if you
Hmm.
are like me, you want to care enough that you're emotionally invested where you give a darn, but you always, not always, but I find that you have to have a little bit of balance to that so you're able to keep up your mental dexterity so you're not getting beat up too much because you still have to take care of the next couple of people. And that just
Right.
takes time. Some people just feel a lot, and that those conversations can be difficult to handle after a while. With those, the way I approach it, because oftentimes it can be where you maybe the first time that you're seeing them or you're seeing them after a biopsy and no one told them the results and they're here to see you because they just had their procedure and we're the physician extenders. So sometimes you're meeting someone for the first time, you don't know their approach, you don't know who's going to be in the room, whether they speak English or not, if you need a translator.
Hmm.
I do find that one, making sure that everyone is on the same page. What do we know up till now? So you know what to fill in
Hmm.
the gaps. Then talking to folks about, all right, what did we find? Explaining it slowly and really trying to add in context. If we're talking about a very common thing that we see is biopsies or prostate biopsy, and that's the big thing.
Hmm.
People want to know if I have cancer or not. Well, with prostate cancer, it's not all or nothing. So before I tell someone, oh, there's prostate cancer there, I really want to make sure I try not to let them mentally escalate too far. I'll have to say, okay, first off, this is why we're trying to kind of ease them into it. This is what we're trying to find from this biopsy and how we went about it. And I'll have
Hmm.
to explain pretty quickly that cancer is not all good or all bad. Some guys can have a low grade prostate cancer that, yeah, you had that diagnosis. You have a prostate cancer diagnosis. We're not going to treat you. It's actually best to leave you alone. The rest of your life, or at least what we're trying to hope, is still going to stay the same. No one's going to be doing
Hmm.
anything different to you. You're not going to have treatment. So if folks are in that space, you need to make sure that you're not just saying, okay, there's prostate cancer there. You also want to be able to back it up and say, okay, what actually is happening too. Because folks want to
Right.
just know the answer too, but those answers can be really heavy. And so I always
Right.
try to engage patients and not just, go over results for 20 minutes and say, all right, what do you guys feel about that too? So keeping them
Hmm.
engaged so you can always get that feedback of what they're responding to. Because sometimes people are pretty blunt. They'll say, okay, yeah, we know the deal. We're okay. Some folks need a lot of hand holding. But I always find that, yes, in the clinic turnover, we get, pressured to sometimes 10, 15 minutes to crank out a visit to see the next person.
Hmm.
You just have to make up for it in the back end too, or hopefully you're in an environment that allots you that space too. because people always appreciate if you take the time to actually explain to them those heavy discussions and let them get out what they need to get out too. It may not even be what you can tell them. They just want to tell someone what's on their mind.
Absolutely. Because a lot of times, too, with cancer diagnoses, for example, it's not enough to just say that you have cancer. They want to know what this means for them. What does it change about their life, or does it change anything at all, which is exactly what you're describing. So I think that's a really great approach, and one that probably a lot more people can use, because I do find even in the hospital setting, I have to almost I usually just start out with my blank question of what do you know about X, Y, or Z? And then I let
Mhm,
them take the floor and let them guide the conversation, because I know that I want to answer their questions while I do my job and communicate whatever I need to communicate to them. So
mhm.
it's a tough conversation to have for sure.
Yeah, it can be, and everyone's different too. So a lot of it is just trying to be confident in your approach. If people see you coming in very nervous, they're going to be a little unsettled too. They may not trust you. There is some of that fake it until you make it. But at the same time, you want to be genuine. If I'm, really, if I have a result and I'm like, this makes me uneasy. I'm not going to come in super excited, but I'll say I wouldn't downplay this. This is how I feel. This is high risk, and explain it. But I'll
Hmm.
also try to soften it and say, but here are the things that we can do about it. We have some knowledge, and you're not. I don't want people to feel helpless about it too. And then
Right.
most of the time, that covers most of those types of heavier conversations. But of course, everyone is different.
Right, right. Another question that I got was, how is it, or I guess what other specialties might you interface with as a urology PA?
Mhm.
Are there other specialties or situations, inpatient or maybe even on the outpatient setting, where you're directly or indirectly interfacing with other specialties?
Yeah, very common. We'll see a lot of primary care referrals, family medicine referrals for, urinary tract symptoms. We'll also get that for, BPH, enlarged prostate, overactive bladder. You'll see referrals plenty for recurrent urinary tract infections. A lot of that. On the hospital side, the same thing. People can have those same types of ailments while in the hospital, so we interact on a daily basis as well. So you're dealing with a lot of on the internal medicine side too. So you get a lot of general medicine exposure. We're not managing as much as those teams are, but on the broad scale. But it's nice. You can dabble and sort of say, okay, I still got it. You'll see their other
Right, right.
treatment patterns too. It's helpful, especially when you come around to those future pan-reads and recertifications. Beyond that, yeah, we very often entailed with nephrology. If you're in the urology space, you'll have to explain to a patient the difference between nephrology and urology. We explain that
Hmm.
they're different, but they're involved and they're very intertwined. I always tell folks in urology, we're like the plumbers. We want to make sure your pipes are flowing, although they can definitely cause
Hmm.
harm to the kidneys. The kidneys that our folks, the nephrology team, are like the HVAC, the HVAC folks, where they care
Hmm.
about the filtration system. There's things that your nephrologist will do to help out with the meat too, but they're both intertwined. Beyond that, oftentimes it's being a surgical subspecialty, making sure cardiology, pulmonology, that everyone signs off with blood thinners or clot
Hmm.
risk before major surgery, getting them cleared for surgery. But those are probably our most common. Interventional radiology, there's things that we can place inside the body, stents or decompress the kidney from an obstructing stone or a stricture. But if we can't get after that, we work very frequently with the interventional radiology if they have to put nephrostomy tubes on the side too. We're not the only plumbers in town. So
Right.
we do get a good amount of touches with a lot of different folks. So it's nice. In my hospital, I don't know everybody. You see a lot of familiar faces, and it's good. You develop a rapport because you're getting that exposure because you're talking and having these consults over time. You see them in the lunchroom, you see them on fifth floor for a new consult. It helps with those newer consults and just rounding throughout the day to have a good rapport. So we're not just completely isolated.
Yeah. And how is it working with residents and other physicians? Do you feel like you've been able to develop a great working relationship with those individuals, and how does that work out in your day to day as far as
Mhm.
delegation of duties, for example?
In my case, it's been, I won't say rare, but a little bit different. Where I've mostly worked in private practice, we didn't have residents. We just basically had the attendings, and they would sort of manage everything on our own. We would cover hospitals that didn't have residents there. So I didn't really have much direct exposure to residents in urology until I
Mhm.
went to the university hospital. And then the few times, and even my site itself, part of why we don't have call ourselves, the residents will not even come to our site either. Our site's actually managed primarily overnight by the attendings, which is somewhat rare.
Mhm.
But so I don't have too much direct exposure. But we have these group, events. You'll have situations where you'll see referrals from our different sites, and it's helpful too. But right now, my exposure to the residents is usually pretty informal, casual settings, which is nice too. You always want to make sure you treat everyone nice, especially someone that's going to be in the field for a long time. Urology, someone told me, is a very small field, and it's true. Even though I was talking about how, yes, the volume is not that big, but there's opportunity everywhere. I've seen a lot of recurring faces from outside the state, from school, from different practices, from different conventions that I've been to. You see a lot of familiar faces, so you always want to just develop a good rapport. Um,
Right.
with regards to the attendings, that can always be quite variable. While I've
Mhm.
had maybe myself, I've reported directly under, I think, probably 25 urologists at this point, which is good. And now I have a nice base now, but I'm glad I got to be under a lot of different teaching styles. Some more older docs that are on their way out of retirement, some folks that are more by the book, more bookish, some folks that are really type A and want everything now
Mhm.
too. Some personalities you just know that, yeah, I don't thrive under this too. And you won't know that until you're under a mentor that is giving you a room to grow and to blossom. I've been in situations where I've had an attending that is, brilliant, but they'll grind you to dust. And I've had other ones that are
Yeah.
more laid back. They'll let you do your own, but maybe they're completely hands off too. So you want to find a good balance. So that's been my experience.
Absolutely. Okay. Okay, so next, I totally lost my place on here. Okay. Um, how do you protect your work-life balance?
Good question. That's very important. Um, yes, and I keep chiming on this whole call thing, but it really, that was a big portion.
It
Be,
helps. It helps a lot.
Yeah, because where I was at too, it's depending where you go, there's different kinds, but I would have one where I was on call one full weekend a month, which maybe is not objectively a lot for some folks too, but that would be a rotating schedule. So I remember the first time I was able to, someone asked me to do something on a weekend, and I didn't have to, like, oh, let me check. Oh, let me just double check. Like, oh yeah, I can do
Right.
it. I have complete control. That was big. Or even some nights we would actually do a couple weeknights too. And even if a call night is, you're not, even if you have nothing going on, I don't know about some folks, you can't there's a level of anxiety that you have at
Right.
all times too, where if it's a quiet night, you're happy that, okay, it's winding down, I can be okay, but you'll be worried that call alarm is going to come off. I remember I was having a little bit of anxiety for a while because even after I stopped being on call from a different job, I remember being in the grocery store and I'll hear someone else's phone that will use
Mhm.
the same notice, and I would instantly
Jump.
just, yeah, jump up, and it would just, that's how ingrained it is to your system. So being in an environment where you feel like, hey, the hours are fine for me. Most urology clinics, unless you find a good gig, are mostly Monday through Friday because they have their outpatient clinics too. But if you can find solo inpatient assisting gigs, maybe you only do, a bunch of surgeries for 3 or 4 days. So that can be helpful.
Right.
Uh, for myself too, is being efficient at work, whether that be learning different micro macro skills with doing your EMR, so you're at least getting through your patients faster. Um, my big thing is I do not want to take work home. Yes, there's things with billing time frame and making sure that you're getting certain notes charted at a certain point in time for whatever incentives and billing, that there's those rules too. But I always try my best to, before I leave, I try to clear everything out. At least enough that I can get done. I do not like bringing work home, although I can work remotely. I used to try that and I realized my brain doesn't shut off. So my whole point is, once I get to work as much as I can, be efficiently as I can. But once I leave, done. Like
Right.
I just don't think about work too. Yeah, sometimes you can prep for the next day, or if you have a big surgery case, you never want to go in completely blind, but I'm a big proponent of, in my opinion, while I value my job, it is a job and it's there to fuel
Hmm.
the other things that I also happen to like outside of a hospital. So that's been my
Absolutely.
approach. Yeah.
Yeah, absolutely. I know that for me, especially when you're in school and you're doing, I'm sure this is very similar even for physicians and many other careers out there when you're going through this very intense graduate education, your career becomes so much a part of your identity because you're just working so hard all the time to make it through that I feel like it's taken some time even for myself to disentangle the fact that well, a lot of what I do is what I do. It's not who I am. I'm so much more than just a PA, even though it's a huge passion. And I think that that's an important distinction that can get cloudy when you're really having to invest in something, maybe for your education, for example.
Yeah, it's natural because when you're coming from school too, we're in that competitive mindset. You're literally competing for your spot at your PA school. You're competing for jobs immediately too. Once you're in a job, yeah, you still need to be sharp too. You're going to compete for jobs in the future. So it's kind of, we're always directly comparing ourselves to our peers. But then after a while, everyone's focusing on themselves. As long as you're giving good quality of care and you know that you have
Hmm.
the support to make those right sound clinical decisions and you feel like life is all right and you're getting through it, then yeah, you'll get to a spot where you feel like you have a good work-life balance too. I mean, while I did have plenty of bad days my first 2 years and even sometimes recently too, I struggle to think of some of my worst days in the field
Hmm.
now, just because we've moved on. I'm like, okay, let me focus on this next thing I'm doing next weekend too. We got through it this week, and just try to focus on the things that make you happy.
Absolutely.
Yeah.
What is your both favorite and least favorite part about your job?
I would say I kind of touched upon it before. I think like my most favorite part of the job is when we get a good outcome. For me, it's maybe as a personality, I don't like leaving things just left as it is. While I always am fine if a patient will, and this maybe ties into the worst, but I'm always fine if a patient doesn't want to pursue any type of intervention. That's okay. They're entirely allowed to say, sometimes I agree, we shouldn't do anything about it. But I do like that when we have something that patient's saying, this is directly affecting my quality of care, we do something, whether it's medication or some minimally invasive procedure. And then 6 to 8 weeks later, I'm seeing them in the post-op or a post-op visit in the clinic, and they're happy. And we're like, awesome, I'll see you in 6 months. I'll see you in a year or two.
Hmm.
That makes me very happy because like, we did the job and we're having some direct impact too. I like that a lot. Something that can be frustrating, and again, maybe it's my own bias, is that not that a patient needs to listen to me. Sometimes you can see if someone, for whatever reason, may have reservation about the clinical better choice of treatment or there's something to do. But some folks will
Hmm.
have maybe some reservations of a past experience, maybe apprehensive, or they want to go more holistic approach, or instead of like getting a type of formal cancer therapy, they want to go to more supplementation. I respect everyone that wants to go different routes too. But as someone that has seen where more often than not those choices end up causing more harm,
Hmm.
those will hang on me for a while. So what I try to do is listen to the patient, explain to them, hey, this is our thoughts, but I want to make sure that we're anything that we do, that you have full on conviction. I never want you to feel like we're doing anything that we have to convince you. As long
Hmm.
as you understand that what our options are and that we have access to solutions, that helps me. You can only do so much, or at least making yourself available to. So, um, you
Absolutely.
know, those are kind of like the highs and lows for me.
Okay. Okay. Last question is can you describe a day in your life in urology?
Yeah, I mean, I almost want to suggest today, but today wasn't too exciting. Today was just a clinic day. For us, we usually get on paper, we get these 30-minute slots, so maybe it's about 14 patients, which is in a university system. Sounds like not a lot, but we get a lot of complex patients, and you're feeding the hospital too in boxes, so that took up my whole day. Um, if in private practice, my goodness, I was cranking out maybe 30, 35 patients a day. I do
Oh
not
my
want to do
gosh.
it. Yeah, it's a whole different. it's a different beast, it's a different style. I feel like now we can actually talk with people more and reach those
Mm-hmm.
highs of highs that I mentioned to you from before. But a fun day will be like a mix. I like my hybrid days where some mornings I'll first assist on a robot case. You come in a little bit early. I'm assisting on a
Mm-hmm.
prostatectomy, and we're removing a prostate or partial nephrectomy or a total, where we're removing a kidney for cancerous or benign masses. That's always pretty cool because I'm still getting used to the robot. I probably had maybe 30 cases under my belt, but I can still sometimes misstep or almost get clocked by one of those robot arms. But
Mm-hmm.
it's very good. It's a different ballgame. You're going from being in clinic all day to learning how to use your left hand to retract some very sensitive bowel and using your non-dominant hand to help inject or staple the
Right.
IVC, some really high high level moves that can really
Crazy.
cause some havoc.
Uh-huh.
And at the same time,
Absolutely.
you're also trying to do suction and clear and making sure that your patient table is okay. So it's all hands on deck. And then you'll switch into maybe rounding in the hospital, making sure that whoever our inpatient set is doing fine. And I'll wrap up in clinic, more outpatient stuff, some of those topics we talked about before. So yeah, wearing a few hats throughout the day. Sometimes it's nice just to do one of those things all day. I do have an all surgery
Mm-hmm.
day too. I don't have an all inpatient day, but there's some days that are more inpatient heavy. So I like that I'm not doing the same thing over and over.
Yeah. It's so nice that you're not really trapped into one setting. Like I would imagine that sometimes if you're strictly an outpatient or strictly inpatient, this is nice because you have such a nice hybrid and you get to first assist still. So you almost get the best of all three worlds, I guess.
Yeah, and getting surgery time, however it takes, is that's key, especially if you want to keep your skill set, keep your hands ready. For a while, I was, I think, out of the OR for like 2 years. But I was lucky enough in
Mm.
a prior job to have an attending who was more old school. It's like, yeah, we've been using PAs for like the last 30 years. Let's do this thing. And I
Come
remember my
on.
hand, yeah, and I remember like my hands were like concrete. I'm like, come on, just like I was just trying to make the knots happen. And it was nice getting my hands back, and then of course, robots is a whole different type of hand too. I like to being able to, really challenge myself and keep those skill sets. And yeah, robot surgery, urology is not the only one that does it. General surgery uses them, OBGYN does. That
Hmm.
robot skill will translate to other smaller fields or smaller subspecialties, but are quite valuable too. Yeah, sometimes I'll say maybe a negative of it would be I would probably be a little more intimidated going into more of a general med space like ER or internal medicine, urgent care.
Hmm.
I do feel like myself specifically having done urology, I've sort of pigeonholed myself into that. But if I really wanted to change, I could. But I feel like I can
Hmm.
find enough roles within urology that fit what I want. More clinic heavy, more procedures, more hospital stuff. I find that I'm liking that too. And I've made a lot of good
Absolutely.
friends and contacts too. I'm attached, I'll say.
Yeah, absolutely. Well, thank you so, so much for getting on with me. I really, really appreciate it. And I think that everybody's really going to like this episode. I know I am fascinated. I think it's such a great specialty. And I really appreciate you taking the time out of your busy, busy life to kind of give some more education and insight into something that's kind of hard to get insight into.
No, of course. And again, I appreciate you inviting me on the Below the White Coat podcast. So I hope this has been helpful. I can ramble at times. And so hopefully your listeners are enjoying or learn something of why they do or don't want to get into urology. If we helped you get some more conviction on your future choices, that makes me
Sure.
happy. Yeah.
Yeah, absolutely. Well, where I you kind of have a social media thing going, so if you want to, I like to open up the space for people to say where they can be found or some kind of way that you like people to reach out to you, however
Sure.
that may be.
Sure. If you'd like to hear more of what I have to say in my own ramblings, I have a social media handle. I am Ben I am at I am Ben I am. I usually just talk about whatever's on my mind on different types of urological health topics. I'm pretty informal. I try to be educational. I try to be silly. A lot of it is just my own creative outlet. So feel free to check it on out. And if you have any questions, feel free to send me a message.
It's hilarious, and I follow you, and I think you're hilarious.
I appreciate that. I try not to laugh too many of my own jokes, so that makes me happy to hear.